Hello and welcome to OneMedicine. Today I'll be talking about genetic disorders of hypopigmentation. So these are the disorders which present with hypopigmentation of the skin, but these are genetically mediated. The normal skin color is determined by the number of variables, of which melanin is one of the important variables which will determine the normal skin color. The differences in skin color is because of differences in the melanin content. So if the melanin content is different, the skin color would be different. It's not only melanin which governs the skin color, but also there is hemoglobin and carotenoids. So hemoglobin and carotenoids also play a role in determining the skin color. So the melanin synthesis happens inside the melanocytes. These melanocytes will migrate from the neural crest into the epidermis during the first 2 months of intrauterine life. So during the 7th or 8th week of life, that is when the melanocytes will be transferred to the epidermis from the neural crest. These are the neural crest derived cells. They produce melanin within specialized cells called as melanosomes. So inside the melanocyte, if we have melanosomes present, inside that melanin is produced. So inside the melanosomes are these melanin pigmentation produced. There are two types of pigmentation basically. We have constitutive pigmentation and then we have facultative pigmentation. Constitutive pigmentation is the amount of melanin is constant here, which is genetically determined in the absence of any exposure. Okay, that is the skin color that the individual is born with, which is constant. Constitutive is constant pigmentation that he has, whereas facultative pigmentation is the tanning or the burning that he gets post exposure to sun exposure or drugs. So it results from sun exposure or exogenous factors like drugs. The hormone which governs the melanin deposition and the melanin synthesis in the pigmentation is the melanocyte stimulating hormone. Also ACTH also plays an important role in governing the pigmentation. So the melanin synthesis happens this way. Here we have tyrosine, which is converted to dopa by tyrosine hydroxylase or tyrosinase. Then dopa is converted to dopaquinone by dopa oxidase or tyrosinase. Now this phenylalanine is an amino acid that will be converted to tyrosine by phenylalanine hydroxylase. So there the enzymatic pathway starts. So until here it's the enzymatic pathway which takes care of the synthesis. After that, spontaneously it can form two things. Dopaquinone, if there is addition of cysteine, they can form pheomelanin, which is the yellow to red color type of melanin, and spontaneously again it will form eumelanin. Eumelanin is the black pigmentation that is formed, or it can form yellow to red color pheomelanin, two types of melanin which are formed. So here on the reaction would be, this is spontaneous reaction, whereas this is an enzymatic reaction which takes place for the melanin synthesis. So here is the migration we can see from the neural crest. It has migrated to the retina, the choroid, the iris, and it has gone to the leptomeninges, to the inner ear, to the Schwann cell, and also to the hair follicle and the skin. So from the neural crest, melanocytes is migrated to all these particular places. So if there's any defect in the enzymatic pathway, or if there's any defect in this migration, then there is disorders of hypopigmentation which is seen. The melanin is not deposited properly and we see disorders of hypopigmentation or depigmentation. Here in this image you can see melanocyte, which is a dendritic cell placed inside the epidermis. In the lower part of the epidermis, the dendrites are placed, the melanosomes. You can see the dotted ones are the melanosomes which contain the melanin pigments. So these melanin pigments will be transferred to the adjacent keratinocytes in the lower part. That's how the pigment is transferred and there is uniform pigmentation of the skin. As the keratinocytes move up and come to the upper part of the epidermis, they will also be shed. So you don't find any pigmentation in the upper part, you only find it in the lower part of the epidermis. Here is how the transfer of the melanin pigmentation, these are the melanosomes which contain the melanin pigmentation, that's how the transfer is happening to the adjacent keratinocyte. There are 4 stages of melanosomes here. In the stage 1, it will be circular in shape, the melanosome is circular and melanin is not produced till. Whereas in stage 2, it will become ellipsoidal or oval or ellipsoidal, and melanin pigmentation starts depositing in this particular stage. Here there will be increased deposition, here there will be more increased deposition. It will be round or oval shaped of melanosomes only in all of these particular conditions. It is a fully developed stage, is the type 4. These are all the stages of melanosome inside the melanocyte. So the disorders of pigmentation would be, we have genetic disorders, then we have developmental anomaly, nutritional disorders, chemical disorders, endocrinological, post-inflammatory, and with hair affected alone. So genetic disorders would be, we have oculocutaneous albinism. In that we have tyrosinase positive negative forms, yellow mutant type, Hermansky Pudlak syndrome. That's one of the type of oculocutaneous albinism. Then you have Chediak Higashi syndrome, cross Breen syndrome, oculocutaneous albinoidism, ocular albinism, Piebaldism, neurocutaneous syndromes like Waardenburg syndrome, Fisch syndrome, Woolf syndrome, Ziprkowski Margolis syndrome, Tietze syndrome, tuberous sclerosis, incontinentia pigmenti acromeans of Ito, which is hypomelanosis of Ito. Then we have Ataxia Telangectasia, also called as Lewy Bar syndrome. Inborn errors of metabolism are Menke's Kinky hair syndrome, Phenyl Ketonuria or hyperphenylalanemia, histidinemia, homocystinuria. The developmental anomalies are nevus depigmentosis, which is also called as achromic nevus, which is nevus depigmentosis. Then we have nutritional disorders like kwashiorkor, ulcerative colitis, malabsorption, nephrosis. Chemicals like monobenzyl ether of hydroquinone, phenolic compounds, thiouracils, mercurials can cause hypopigmentation. Endocrinological disorders like hypopituitarism, Addison's disease, hyperthyroidism, and hypogonadism. Inflammatory disorders like infections in fungal, bacterial, treponemial, viral, pictozoal. Non-infective like pityriasis alba, rosea, eczematous dermatitis, psoriasis, lichen striatus, lichen planus, DLE, morphia, lichen sclerosis, atropicus. Mechanical disorders like mechanical injury, thermal injury, radiations. Other important disorders like vitiligo. Then we have idiopathic guttate hypomelanosis, halonevus, Alexandrini syndrome, Vogt-Koyanagi-Harada syndrome. Only affecting hairs, we have Fanconi syndrome, Rothman-Thompson syndrome, Book syndrome, myotonia dystrophica, progeria, Werner syndrome, Seckel syndrome. So all of these are the various syndromes which are associated with pigmentary disorder. We'll talk about certain genetic disorders now. Firstly, we'll talk about Piebaldism. It's a rare autosomal dominant disorder. So Piebaldism is a rare autosomal dominant disorder of melanocyte development. It's a stable condition which does not progress but seen since birth, wherein we see depigmented skin with white hair or white forelock. On the face, on the forehead, there'll be triangular patch of depigmentation along with the hair also, which will be depigmented or white in color. That's the white forelock. And on the rest of the body also, there will be depigmented patches present. Okay, on the anterior part mostly, and on the limbs also it can be present. Depigmented patches can be present, but the associated feature is in this particular depigmented patch, and also in this particular patch, there will be hyperpigmented macules scattered. So hyperpigmented macules in that patch also it can be present. Okay, so this is the manifestation that it basically has. 1 in 20,000 births it is seen, and males and females are both equally affected in this particular condition. So there's a mutation in this KIT gene. KIT gene is mutated in Piebaldism. This mutation will lead to impaired migration would be affected. Migration of melanocytes from the neural crest to the epidermis would be affected here. Migration does not take place here. Okay. Heterozygous mutation in zinc finger transcription factor also has been associated. Not only that, even this mutation. So these two mutations are basically involved in the Piebaldism. Absence of melanocytes in the hair bulb and in the hypopigmented areas, there will be absence of melanocytes and melanin with negative dopa reaction. In the hyperpigmented macules, there will be abundant melanosomes present, and the affection here would be differentiation, migration, survival of melanoblast will be affected. The clinical features would be the white forelock that I described to you before, with V-shaped area of the leukoderma on the mid-forehead. Since birth it will be present. The hypopigmented lesions will be present on the anterior part of the body, mid portion of the limbs, on the upper chest, abdomen, limbs, face, chin, calf. You can see the patches present, white patches. Even eyebrows and eyelashes can be affected along with the forelock, and that can be present continuously or discontinuously with the forelock. The lesions are bilateral but they are not symmetrical. Hands, feet, back are normal. It won't be affected here. Now, the lesion, as I told you, will involve the anterior surface, midline will be affected. This will be affected. This will be spared. The dorsal area won't be affected. It will be normal in pigmentation, because the neural from the neural crest on the back side, the neural from melanocytes has to progress and come to the front of the body from the dorsal area, and they will fail to reach this part, the anterior part. There will be normal pigmentation here, but to reach here, they'll fail to reach in the anterior part of the body. So therefore, since melanoblasts have not reached this anterior part, the pigmentation on the anterior part would be affected. On the dorsal side, it would be normal on both sides. So that's why we see anterior midline which is affected here, okay? And that is explained by the impaired migration of melanoblast failing to arrive at distal sites. It is not usually associated with any extracutaneous manifestations. Sometimes mental retardation and deafness can be present, and heterochromia iridis can also be present. We have to differentiate it from vitiligo. These are stable lesions. Vitiligo will progress, whereas this is stable lesion. If the interpupillary distance increases and if there is deafness, then Waardenburg syndrome has to be kept in mind. Waardenburg syndrome is another neurocutaneous disorder. So if that is there, then this syndrome has to be kept as a differential diagnosis. So here you can see the white forelock with the white hairs and the depigmented patch on the leg. Here you can see the depigmented patch, hyperpigmentation in between. Differential diagnosis would be vitiligo, alopecia areata, Woolf syndrome, Alexander syndrome, Woolf syndrome, Waardenburg syndrome, nevus depigmentosis. Sun protection, epidermal cell grafting, phototherapy, corticosteroids are the treatment. Next syndrome is Waardenburg syndrome. Here it is an autosomal dominant disorder. It was described by Petrus Waardenburg in 1951. Here we have three things: Piebaldism, pigmentary anomalies of the iris, and then sensorineural hearing loss is present. There's 4 types, 1 to 4 types of Waardenburg syndrome is there. All of them are autosomal dominant except this 4th type, which is autosomal recessive type. Pathophysiology, it involves neural crest lineage. In type 1 and 3, there is PAX gene mutation. In type 2, there is MITF gene mutation or slug gene mutation. In type 4, SOX10 mutation, EDNRB, EDN3 mutation. In type 4, associated with the SOX10 mutation, will have Hirschsprung's disease associated, which leads to abnormal expression of RET. So there is melanocytes which are absent in the depigmented skin, and melanocytes are reduced in the surrounding periphery. Normal skin will have mixture of abnormal and normal melanocytes. Auditory and pigmentary deficits are secondary to melanocyte differentiation failure. So melanocytes are important in inner ear cochlea and also for pigmentation. So both of that would be affected. Clinical features in Waardenburg syndrome: patient will have a piebaldism pattern along with sensorineural hearing loss, and areas of hyperpigmentation may arise and they diminish in size or disappear with time. Clinical variants are 1, 2, 3, 4 types of Waardenburg syndromes are there. And type 3 is also called as clean Waardenburg syndrome. Type 4 is also called as Shah-Waardenburg syndrome. So Waardenburg syndrome type 1, here it is autosomal dominant disorder. PAX3 gene is basically mutated here. Here the findings that we see are the white forelock, alopecia, hyperpigmented patches, dystopia cantharum. Dystopia cantharum is the medial end of both medial canthus of the eyes are laterally displaced. That is, dystopia cantharum is present here. Heterochromia iridis, congenital deafness. Broad nasal root, sign of risk, that is the medial hyperplasia of the eyebrows. Mild skeletal abnormalities would be present. So here you can see the Waardenburg syndrome: heterochromia iridis, broad nasal root, medial hyperplasia of the eyebrows, interpupillary distance is increased along with the piebaldism pattern present. So Waardenburg syndrome type 2, here it is again autosomal dominant. MITF, microphthalmia associated transcription factor is mutated or slug gene is involved here. Clinical features like type 1, but there is no dysmorphism of face or there is no dystopia cantharum, but deafness and heterochromia can be present. In type 3, which is autosomal dominant again, PAX3 gene is again mutated here. It's a rare type, similar to type 1, along with musculoskeletal features are present here, like syndactyly hypoplasia is present. Type 4 type associated with Hirschsprung's disease, SOX10 mutation, autosomal recessive. This is all others were autosomal dominant. So here are the genes which are affected here and the corresponding features which we just discussed. In this photograph, you can see the white forelock and the facial features here, okay? The ribs are supernumerary, so it's a type 3 type of Waardenburg syndrome, which is PAX3 gene which is involved here, along with musculoskeletal features. Diagnostic criteria, we need at least 2 major criteria, or we need 1 major plus 2 minor criteria for diagnosis. So the major criteria would involve characteristic white forelock, pigmented anomalies of iris, congenital deafness, dystopia cantharum, first degree relative. Minor criteria is depigmented macule, sign of risk, broad nasal root, nose hyperplasia, graying of hair in less than 35 years, premature graying. Management, it's a non-progressive hearing loss, no audiogram to be done. Woolf syndrome is the next syndrome. It is an autosomal recessive disorder. There will be piebaldism, deafness, mental retardation here, because all of these melanin synthesis would be affected there. Histologically, there is absence of melanin, melanocytes in the depigmented patches, which is DOPA negative. There is alteration in the neural crest seen here. Next is albinism, which is one of the most common disorders of hypopigmentation that we see. So here the patient will have a congenital disorder of either partial or complete loss of melanin pigmentation in skin, hair and eyes. So all these three structures would be affected here. If only skin and eyes are affected, it is called oculocutaneous albinism, which is autosomal recessive. If only eyes are affected, it is X-linked recessive. Etiology, there will be failure and the enzymatic defect will be there in tyrosine synthesis or tyrosinase enzyme. Commonest disorder of generalized hypopigmentation. Etopathogenesis, as I told you, the enzymatic pathway that I explained to you before, that will be defective here. Or melanosomes, which contain the melanin pigment, would be defective. And there will be decreased transportation of these melanin pigmentation to the keratinocytes. So classification, 4 important types are 1 to 4. And 5, 6, 7 has also been described here. Oculocutaneous albinism. Type 1 is 1A and 1B, wherein 1A is complete loss of pigmentation, 1B is partial loss of pigmentation. 2, 3 and 4 types are basically present. So you can see all of them are autosomal recessive except ocular albinism, which is X-linked recessive type. So oculocutaneous albinism type 1, there is complete loss of pigmentation. TYR gene is involved here. Patient will have white hair, white skin and blue eyes because of loss of pigmentation, but the structure would be normal. In type 1B, there is partial retention of pigmentation with the varying degrees of pigmentation progresses. Axillary and scalp hair would be yellow in color, limb would be normal pigmented. In type 2 there is eumelanin, which is defective. Pheomelanin would be normal here. White skin is present and other features like there will be UV induced features like lentigenes, pigmented nevi can arise. Hair will remain yellow color. In type 3 is brown or red colored OCA, oculocutaneous albinism, and TYRP gene is mutated here. In type 4 there is generalized hypopigmentation and ocular abnormalities. Membrane associated transporter protein defect is seen. Type 5, 6, 7 are the minor variants which will have white skin, golden hair, and consanguineous Pakistani family. It was described. Yellow hair, brown iris, light hair, yellow hair, white skin. So white skin, yellow hair is present in all of these. Next we have only ocular albinism. Only eyes are affected, which is X-linked recessive. Only eyes affection you see here. It's a congenital disorder, congenital nystagmus, hypopigmentation of iris, and you see reduced retinal pigmentation, foveal hypoplasia, reduced visual acuity. One of the important features again is photophobia. Patients will have photophobia here, okay. And also one of the other important features is there will be misrouting of the optic nerves, which will cause strabismus. So strabismus features would be present here, along with refractive errors which can be seen. The most common manifestation that oculocutaneous albinism will present is with freckles. Freckles is the first manifestation that they will come with. Differential diagnosis of oculocutaneous albinism would be histidinemia, homocystinuria, Phenyl Ketonuria, Hermansky, Pudlak syndrome, Chediak, Higashi. These are again oculocutaneous albinism would be present in these particular conditions also. Treatment, no specific treatment. Photoprotection, sunscreen, hats, clothing has to be done. Eye protection, ophthalmologic examination. Nitisinone is one of the drugs which can be used to treat this. Regular checkups for skin cancer needs to be done. So this is a family which shows 2 children which are affected and 1 child which is normal. Here it's a family, parents are normal but the children are affected. They are albinoids here. Here is again a cutaneous feature of albinism. Here is a baby and later in life the same baby with white hair and white skin present. Here you can see the type 2 type of OCA which presents with pigmented nevi. Here you can see the SCC which is developed and lentigenes which are seen here. These are lentigenes and this is the SCC which is developed. Hermansky-Pudlak syndrome. Hermansky-Pudlak syndrome is a rare type of oculocutaneous albinism. There will be oculocutaneous albinism along with hemorrhagic diathesis present in this condition. Okay, hemorrhagic diathesis would be present in this particular condition. 9 types are basically there, reported in southern Holland and Madras. It's in Puerto Rico also. So there will be some abnormal synthesis of lysosome related organelles with impaired melanosome maturation and absent dense bodies. Since maturation of melanosome is not there, pigmentation would be affected. There will be hypopigmentation. Then because of absence dense bodies, bleeding would be seen. Increased bleeding tendencies would be present here. Okay, there are 9 types, 1, 2, 3, 4, 5, 6, 7, 8, 9 and the respective genes which you don't have to remember so much. Clinical features, you find oculocutaneous albinism along with hemorrhagic diathesis. Those are the diathesis. These are the 2 important features. The storage pool of platelet which has aggregating property will be lost here. That will not be present. Spheroid-like material will be deposited in various organs. If that is deposited in lungs, it will cause severe pulmonary fibrosis. The skin would be reddish brown in color. Hemorrhagic diathesis would be bleeding after tooth extraction and delivery, which can be fatal. The life expectancy is 30 to 50 years in Hermansky-Pudlak syndrome. Electron microscopy will show absence of dense bodies in the platelets, and it contains ATP, serotonin, calcium phosphate. CT scan of chest and PFT can be done for lung fibrosis. Molecular analysis will confirm the diagnosis. Then you have another syndrome called Chediak Higashi syndrome. It is an autosomal recessive condition. Autosomal recessive lethal disorder. This is okay. It can be dangerous. It can be fatal. There is hyperpigmentation of the skin and eyes. Then there is immunodeficiency, which cause recurrent infections. Then there is neurological abnormality, and then there is hematological abnormality. And death is seen by teenage. Death can be seen. So since skin and eyes are affected, pigmentation would be gone in these particular cases. Because of immunodeficiency, repeated infections would be seen here. Neurological manifestations and hematological manifestations are seen in this particular condition. This mutation in this particular gene called as LYST gene, LYST gene, would be mutated here, which encodes lysosomal trafficking regulator. If this mutation will cause impaired protein synthesis, and it will affect the storage and secretory granules of various cells like leukocytes, fibroblasts, dense bodies of platelets, neutrophils, melanocytes would be affected. Since the organelles of these particular cells are affected, their functioning would be affected. Since the leukocytes and neutrophils organelles are affected, they don't function. Okay, then that will cause increased infection. Dense bodies of platelets won't work, so bleeding diathesis. Melanocytes won't work, so there will be pigmentary abnormality. So all of that would be seen. Melanocytes have giant pigment granules arising by autophagocytosis and defective fission of large melanosomes. Clinically, you see there's fair skin, pale retina, translucent iris. Skin color would darken with time and sun exposure. In eyes, you see there's translucent iris, blue to violet color iris, twin photophobia, decreased retinal pigmentation. With pyogenic infections, neutropenia, giant inclusions in the neutrophils would be present. Okay, so neutrophils will have giant granules would be present in the neutrophils also. Highly susceptible to viral bacterial infections. Death is because of respiratory infections, neutropenia, thrombocytopenia, convulsions, neuropathy. Later stages in the accelerated phase, phase of Chediak Higashi, they will have lymphadenopathy, jaundice, leukemic gingivitis. Failure of immune surveillance will cause lymphoma-like features. The CNS manifestations would be this: it is progressive, you cannot halt it. Progressive intellectual decline, cranial palsy, ataxia, coma, gait problems, seizures, decreased deep brain reflexes would be present, and tremors also. So here is a child with Chediak Higashi with Piebaldism who was treated. Look at it as albinism features. Management is by giving peroxidase positive giant inclusions in leukocytes. Light microscopy will show pigment clumping. This pigment clumping would be, there will be small regular pigments, melanin clumping inside the hair shaft here. Okay, most important treatment is to give bone marrow transplantation and then rituximab cyclosporin. So Griscelli Prunieras syndrome, which is a milder variant of it is a mild form of the Chediak Higashi syndrome. It's autosomal disorder wherein there is silvery grey hair present, large clusters of pigment in the hair shaft. Here it is small and large clusters which are present. Melanin clumps would be present, both small and large, whereas in Chediak Higashi only small regularly arranged melanin pigment clumps were present. And it's a primarily neurological impairment which is present, which is of severe immune disorder. So there are three types, type 1, 2 and 3 present here. Primary CNS in type 1, type 2 hemophagocytic lymphohistiocytosis, type 3 only partial albinism. Silvery grey or silvery golden hair would be present. So there are three silvery hair syndromes here. We have Chediak Higashi syndrome, then we have Griscelli syndrome, then we have Ehlers-Danlos syndrome, which presents with silvery hair. Ehlers-Danlos syndrome. Differential diagnosis would be Chediak Higashi and Ehlers-Danlos syndrome, treated with bone marrow transplantation. Cross syndrome or Kramer syndrome, autosomal recessive, hyperpigmentation with white silvery hair, then severe mental retardation, they will have spastic tetraplegia, epitosis, eyes will have microphthalmia, small opaque cornea and nystagmus, Amish gypsy families, we see this condition. In Ziprkowski Margolis syndrome, it's an X-linked recessive condition. The thing here is they will have congenital deafness and partial albinism, along with Piebaldism pattern, hyperpigmentation of scrotum, and deafness will be present, which is subtotal sensory neural hearing loss present, heterochromia iridis also. So this is the Piebaldism pattern and the pigmentation. Hypomelanosis of Ito, also called as incontinentia pigmenti acromians of Ito. So this is the synonym for it. So it's a neurocutaneous syndrome with females who are affected, autosomal dominant, decreased number of melanocytes containing fever melanosomes will be present. So depigmented macules will be present, which appears years after birth and they fade in later life. Neurological involvement along with the ectodermal defects will be present here. There will be the characteristic feature is asymmetrical, bilateral, bizarre whorls and streaks of hypomelanosis in a marbling pattern along the lines of Blasco. So along the lines of Blasco, there will be marbling pattern of depigmentation present or hypopigmentation. Other associations would be Cafeola macules, cutis marmorata, angiomatous nevi, nevus subota, dermal melanosis, teeth, hair, nail defects would be present. CNS features associated with Hypomelanosis of Ito is mental retardation, seizures, language disabilities, motor system dysfunction, agenesis of corpus callosum, ventricular dilatation, focal cerebral atrophy, and cerebral hypoplasia. Ocular features like ptosis, symblepharon, corneal opacities, myopia, cataract, strabismus can be present. Skeletal abnormalities like short stature, scoliosis, skin dactyly, polydactyly, brachydactyly, asymmetry of limbs are present. So if the patient has got the holes and streaks of pigmentation along with CNS, ocular and skeletal features, then we think about the hypomelanosis of Ito. Okay. So here you can see the holes and streaks of pigmentation which follows the lines of Blasco in a marbling pattern. On the back side you can see the pigmentation. Next syndrome is Ataxia Telangectasia. Ataxia is the cerebral ataxia that the patient has, and telangiectasia is cutaneous or the ocular cutaneous or the ocular telangiectasia that the patient has. Autosomal recessive disorder, depigmentation along the extremities and trunk, premature graying of hair, cerebral ataxia, chorioidosis, telangiectasia, bronchiectasis, recurrent pulmonary infections are present. In ash leaf macules, it is present in tuberous sclerosis. On trunk and buttocks, we see discrete hypopigmented lance ovate shaped and the patch present here. Associated with other features of tuberous sclerosis like angiofibroma, shagreen patch, periangual fibromas, these are also called as Conan tumors, which are present in this particular condition. Tietze syndrome is another syndrome, autosomal dominant disorder, wherein there is deafness, albinism, white eyebrows, and eyelashes. Fisch syndrome, it is similar to type 3 of Waardenburg syndrome, which has skeletal features. Premature graying of hair and congenital deafness is seen in this condition. Bad syndrome, there is black hair amidst white hair. There is albinism seen. There is deafness, sensorineural type of deafness present here, that is bad syndrome. Along with that, there can be features of photophobia, nystagmus, foveal hypoplasia. Metabolic disorders which present with hypopigmentation are phenyl ketonuria. As I told you before, phenylalanine is converted to tyrosine. Tyrosine then forms melanin after many steps. So this enzyme is phenylalanine hydroxylase to convert phenylalanine to tyrosine. So this enzyme would be defective in phenyl ketonuria. So there will be raised phenylalanine levels seen. Defective enzyme is phenylalanine hydroxylase, autosomal recessive condition. So hyperphenylalaninemia, phenylpyruvic oligophrenia, phenylacetic oligophrenia is seen here. There will be, since there is no melanin present here, light colored skin, hair and eyes is present. Musty odor, or it is also called as mousy odor, which is present because of increased phenylalanine which is seen. Photophobia is present because pigmentation of the eyes also is affected. Then early therapeutic intervention to prevent mental retardation and neurological disorders has to be done. Dietary intervention and enzyme replacement therapies are basically these are the two treatment options which are available. Next metabolic syndrome is Menke's kinky hair disease. It is an X-linked recessive condition wherein defective gene is ATP7A gene is defective. In the intestine, there will be normal absorption of copper, but the transport to other tissues does not take place here. The clinical features is there will be fine, white, silvery, wiry hair, twisted hair, doughy skin, connective tissue disturbances, progressive neurological deterioration, generalized hypopigmentation, seborrheic dermatitis like features. This copper is a cofactor for many important enzymes like lysyl oxidase or dopamine hydroxylase, or it is also required for many other enzymes which are basically involved in connective tissues or for the neurological development or for the pigmentation of the skin. It is involved. but if that enzyme is defective, the cofactor of copper is not available, there will be multisystem lethal disorder of copper metabolism. So copper is not deposited in the tissues. That is why we see this. So if we see the serum copper levels and ceruloplasmin levels would be very less in these particular cases. Treatment with histidine copper can be done to reverse the features.